So today we begin with subfertility module, and today is an important guideline which we are going to discuss. It's a NICE guideline, fertility problems, assessment and treatment. It is a NICE guideline which is published in 2013, 20th February 2013. We begin with our quote, Master MRCOG with concept oriented clarity. This guideline is going to be very, very important from the examination point of view because there will be many SBAs as well as EMQs from this particular guideline. So we start with this guideline. So basically, when the patient or the couple comes to for the fertility treatment, what in general discussion should involve as far as the fertility is concerned. What we should discuss with them that more than 80% of the couples will conceive within 1 year if the woman's age is less than 40 years, they are not using any contraception, and if they are having regular sexual intercourse. See, this is very, very important. This is an SBA single based answer question they are asking over here, that how many couples will conceive within 1 year. They may give you scenario such and such couple where the wife's age of the wife is this, and the couple is keen to know that what are their chances of conception in or they are having a query regarding how much time will they take for the conception. So more than 80% of couples will conceive within 1 year if the age of the woman is less than 40 years, they are not using any contraception, and if it is a regular sexual intercourse. Of those who do not conceive within 1 year, 50% will conceive in the second year, and the cumulative pregnancy rate will be 90%. That means 20% will not conceive. Out of that 50% means additional 10% will conceive in the next 1 year. So the cumulative pregnancy rate becomes 90% over a period of 2 years. Again, this is a SBA. They may ask you for 1 year success rate. They may ask you success rate for 2 years. Okay. So accordingly, your answer will be 80% or 90%. Okay. Then the couple may be on the IUI protocol. The first what we had, the discussion was pertaining to the natural conception. Now, if the couple is on IUI for some protocol, then what advice we should give, that if we give 6 cycles of IUI, then the chance of conception for a lady who is less than 40 years is more than 50%. So she is likely to conceive in first 6 cycle. There is a 50% chance. Okay. And if she does not conceive in first 6 cycles, then we give additional 6 cycles. Okay. And over a period of 12 years, there is a 75% chance. So in another 6 cycles, further chance is increased by the 50%. Okay. So sometimes they confuse in the wording. Okay. That what is the chance, how many percentage of patients who did not conceive will conceive in the another 6 cycles. Okay. Same thing they can ask you here, how many additional couples will conceive. So additional 50% will conceive. Okay. So 80% have conceived in 1 year. Okay. In next 1 year, additional 50% or additional 10%, whichever is an option that you will be choosing. Okay. 50% of non-conceived, that means it is 10%. You got it. And here it will be 50% in the first 6 cycles and additional 50% those who did not conceive. So that is 25%. So total becomes 75%. So you read the question carefully and then you choose the answer. Okay. So regarding the IUF, what further guideline says, it is a fresh sperm which is better than the frozen thawed form, and that has got a higher conception rate. Okay. So the guideline is talking about the fresh sperm or the frozen thawed sperm. It is a fresh sperm that will give you higher conception rate, and IUI is better than the intracervical insemination. Okay. Even if you use frozen thawed sperm, it is intrauterine insemination is better than the intracervical insemination. Okay. So always remember, from examination point of view, it is IUI which will be preferred over the intracervical insemination. Okay. Now the guideline further talks about the age of the couple. Okay. Both male as well as female. Okay. So female fertility declines with the age. Male fertility also declines, but to a lesser extent. Okay, so female fertility will decline with age, male fertility will also decline, but to a lesser extent. Okay, frequency and timing of intercourse and insemination. Okay, vaginal intercourse every 2 to 3 days will optimize conception rate. Okay, avoids need for ovulation prediction kits in routine advice if they have regular sexual intercourse every 2 to 3 days. Then artificial insemination, when should the IUI should be done? IUI should be timed around the time of ovulation. Okay. Then about the lifestyle factors, what the guideline talks about, the alcohol, the smoking, caffeinated drinks, that we are going to discuss. Okay. So about the alcohol for the lady. Okay, recommended intake when trying to conceive should be less than 1 to 2 units once or twice weekly, and she should avoid intoxication. Okay, so intoxication should be avoided and intake should be less than 1 to 2 units. While for male, it should be whatever the limit which is set by the Department of Health, less than or equal to 3 to 4 units per day can be permitted. Okay, so for lady, 1 to 2 units once or twice weekly, and excess intake may reduce fertility, increase risk to the developing fetus if she is drinking, and advise minimal intake. Okay, for the lady, 1 to 2 units once or twice weekly, excess intake will have the effect on fertility, increase risk to the developing fetus because of the alcohol, and advise minimal intake. For male, it should be less than 3 to 4 units per day, moderate intake, unlikely to affect fertility, and it is detrimental to the semen quality, and advise moderation in the intake of the alcohol. So that is what the guideline says. Okay. Now, what about the smoking? So for female, active smoking will reduce the fertility. It is likely to reduce chance of conception. There is a clear negative effect, and what we need to advise, we need to offer them smoking cessation referral. Okay, for male, definitely it is associated with the reduced semen quality. Overall impact is uncertain, but stopping of smoking will improve the general health. Okay, then what about the caffeinated beverages? There is no consistent evidence linking tea, coffee, cola with fertility problems. Okay, but there is an association with the obesity. Now, as far as the caffeine is concerned, when last time we have discussed the guideline of recurrent pregnancy wastage or recurrent pregnancy loss, where they have mentioned the association with the coffee or caffeine more than 200 milligram per day is associated with recurrent miscarriage. While when we are discussing about the fertility, there is no consistent evidence linking. So even when the same question is asked with reference to what context they are asking, that you should know. Okay, so don't get confused. Okay, so here caffeinated beverages, no consistent evidence linking has been mentioned. Then coming to the obesity. Now, if the lady is more than having the BMI of more than or equal to 30, then it is likely that she will have a longer time for conception. And if she is anovulatory, even the weight loss will increase the chances of conception. So best strategy is a group program rather than it is giving an advice to an individual patient. Okay, so it's a diet plus exercise should be promoted. So she will have waiting time for the conception more if she is BMI of more than or equal to 30, and only weight loss will also increase her chances of conception. For men, BMI more than or equal to 30 is associated with the reduced fertility and poor semen parameters. Okay, so from examination point of view, every 2 to 3 days intercourse is optimal. Then IUI is always preferred over the intracervical insemination, that we should remember. And modifiable factors like smoking, alcohol, obesity, we need to work on the lifestyle factors and avoid unnecessary interventions early. So especially these things are going to be very important from part 3 examination point of view, where in the lifestyle and communication skill, we need to assess the these lives modifiable factors, and we need to give the appropriate advice. Okay, now the guideline talks about the folic acid supplementation. What should be the dose and how much should be the duration? So all women intending pregnancy should be given a folic acid of 400 microgram or 0.4 milligram per day, and it should be started pre-conception. Okay, and it should be continued till 12 weeks of gestation. Okay, those women or women which require higher dose, that is 5 milligram per day, the indications are if she has got a previous infant with neural tube defect, if she is on anti-epileptic drug, or if she is a case of diabetes mellitus. These three ladies will require a higher dose, that is 5 milligram per day. Okay. Now coming to the definition of infertility as such, and the when to refer. Okay. So it is a failure to conceive after a defined period, after which formal investigation and possible treatment is indicated. Okay. So assessment should include the lifestyle, the sexual history, and we should take the into account both partners. Okay. So we have to talk to the couple as such. We need to take the lifestyle history, sexual history. Okay. So normally with a regular unprotected intercourse, we expect that 1 year we should allow them to have natural intercourse, and after that we should assess them if they do not conceive. So time before assessment is 1 year. Okay. If it is a they are on a regular unprotected intercourse where the uh, woman is in the uh, young reproductive age group. Okay. IUI, after 6 cycles, if she does not conceive, then we will go for assessment. If she is more than or equal to 36 years, then we will advise early referral. Okay. If she is known to have additional risk factor, such as maybe PID or any other factor which will reduce her fertility, again we have to advise early referral. They have not specified what duration, but guideline just mentions that early referral is indicated. Okay. Then if she is receiving some cancer treatment like gonotoxic treatment is planned, then it is an immediate referral for fertility specialist we have to do. Okay. So what are the investigations for fertility problems? There are investigations for male, there are investigations for female, but as far as male partner is concerned, certain things which you should not select in the option in the examination are certain key rules you should remember, that do not screen for anti-sperm antibodies. If the semen analysis report is abnormal, then you have to repeat the test. Okay. But in the option you will find when to repeat. Okay. They will give you 2-3 options. Okay. So if it is an abnormal, then ideally you have to repeat after 3 months. Okay. But if it is a first report is showing azoospermia or severe oligospermia, then you have to repeat it immediately. Otherwise, you will repeat it after 3 months. But if it is a complete azoospermia or severe oligos, that is less than 5 million per ml, then you will repeat immediately. Okay. So that option you will select. Okay. If there is no azoospermia or severe oligospermia, but overall report is abnormal, then you will select. Suppose if it is a 15 million in that particular case, less than 15 million, in that particular case you will go ahead with the repeat after 3 months. Okay. Then postcoital test also is not recommended, and there is no predictive value for pregnancy rate. You should also know the normal semen parameters. They are always asked in the examination. Okay. Sometimes in part 1 also it is asked. Okay. So this is the WHO reference values for the semen analysis. Okay. Volume should be more than or equal to 1.5, pH should be more than or equal to 7.2, sperm concentration should be more than or equal to 15 million per ml. Okay. Total sperm count should be more than or equal to 39 million per ejaculate. It is per ejaculate, and concentration is per ml. Okay. Then motility should be overall 40% should be motile, 40% or more should be motile, out of which 32% or more should be progressive motility. Vitality should be more than 58% should be live, and morphology at least 4% normal forms. So they can ask any of the parameter in the SBA. So this particular slide is going to be very, very important. All parameters you have to know. Okay. Sperm concentration, if it is given ask in per ml, then more than or equal to 15 ml. Per ejaculate, more than or equal to 39. Motility, total motility of 40%. However, progressive motility 32%. Okay. Then vitality 58% and morphology 4%. Okay. More than or equal to 4%. These are the parameters which you should know. Then what about the ovarian reserve testing? So the best predictor is the woman's age. Okay. So best initial predictor is a woman's age for both natural as well as IVF success. Okay. Now, which are the parameters that will predict the response to gonadotropin when you are when the lady is undergoing IVF treatment? we are worried about ovarian hyperstimulation syndrome, as well as we need to know what is going to be her response to the gonadotropin. Okay, so there may be high response, there may be low response, both are unwanted. So what parameters will tell us about the ovarian reserve? Her antral follicular count. Okay, so the low response is antral follicular count less than or equal to 4, AMH less than or equal to 5.4 picomole per liter, and FSH of more than 8.9 international units per liter. Okay, all these three values you should remember. Okay, because they are asking in the SBA or sometimes in EMQ also part 2, they can give you these particular values. And even in part 1, they are asking these values in the data interpretation. Okay, so it will be a low response if you see these particular antral follicle count less than or equal to 4, AMH less than or equal to 5.4 picomole per liter, FSH of more than 8.9. High response will be more than 16, AMH of more, AFC of more than 16, AMH of more than 25 picomole per liter, and FSH of less than 4 international units per liter. Okay, so low FSH, high response, high FSH, low response, AFC low, AMH low, then low response, and AFC high, AMH high, high response. Okay, so individually for predicting the ovarian reserve, ovarian volume, ovarian blood flow, inhibin B, estradiol, they are not to be taken into account. Okay, so you will take into account the AFC, AMH, and FSH only. Okay, and best predictor for initial predictor will be the woman's age for the success. Okay, now coming to the ovulation assessment, again they are asking SBA here, if her cycles are regular, then mostly she is ovulating. Okay, so that is one of the overall you can say that regular cycles are likely to be ovulatory. Okay, then how will you come to know? By progesterone testing. And when the testing should be done, it is a mid luteal serum progesterone if she has got a 28 days cycle. Okay, sometimes they will give you the length of the cycle, say around 38 weeks, 35 38 days, 35 days, and they'll ask you when will you do the ovulation testing. Okay, so test will be serum progesterone, and in that particular case it will not be on day 21. Day 21 it is a for 28 days cycle, so you have to calculate if the length of the cycle is different. Okay, so accordingly you will choose the answer depending upon her cycle length. Okay, because here what is the concept which is used? The luteal phase is constant 14 days. Okay, the follicular phase will vary. Okay, so accordingly you have to, if it is a 35 days, then you will do it on 28 days. Okay, so adjust the timing for longer cycles, repeat weekly if cycles irregular. Okay, so when the question is given, please read the length of the cycle, just don't go ahead with the day 21 cycle. Okay, then what is not recommended is a basal body temperature charts is not recommended. If she has got a irregular cycles, then you will measure the FSH and LH also. Prolactin routinely not measured, but it will be measured if there is ovulatory disorder, galactorrhea, or pituitary tumor. Okay, if these things are there, then you measure the prolactin level also. Thyroid function, routinely thyroid function tests are not recommended. They will be tested only if she is symptomatic. Endometrial biopsy is not recommended for the luteal phase defect. There is no evidence of treatment improves the pregnancy rate. Okay. Now, coming to the uterine and tubal assessment. Okay, so which test? HSG, laparoscopy, hysteroscopy, what the guideline says? Suppose she does not have any high risk factor which will affect her fertility, such as there is no history of PID, ectopic, or endometriosis. The test for uterine tubal assessment will be HSG. Okay, so we don't go ahead with the invasive investigations initially if she does not have the high risk factor or the comorbidities such as PID, ectopic, endometriosis. If such factors are not there, then the test of choice will be HSG. Okay, and if the expertise is available, then HICOC. Okay, that is contrast sonosalpingography. Okay, so that is what is the guideline is saying. Then if these comorbidities are present, suppose there is a history of PID, ectopic, endometriosis, then you will go ahead with the lap and dye test. Okay, hysteroscopy is not routine, only if clinically indicated, then you will offer hysteroscopy. So see the scenario what they have given. If she is say having a previous or past history of any comorbidity which will reduce her fertility, then go ahead with the lap and diet test. Okay, if there is no such history, then HSG will be the test of choice. Now, these were the basic investigations for the male and female. Apart from that, what other blood tests you have to do? You have to do the viral testing for HIV, Australia antigen, and hepatitis C. Okay, so if these tests are positive, then you will refer them for the specialist counseling and further management, because these diseases can be transmitted also. So we have to do the shared decision making. This is very, very important, shared decision making. So if there is a viral transmission in fertility, fertility management decisions will be made jointly by the couple, the fertility specialist and the HIV specialist. So when you are having multiple options in the as EMQ, in that particular case, choose the option where there is a shared decision making. Okay, so objectively your answer may be correct, but if the scenario mentions the counseling or any specific such factor is required, shared decision making, then choose your correct answer which is associated with this shared decision making. Okay, so what does the guideline say if the husband is HIV positive? Okay, so there is a negligible risk of HIV transmission with unprotected intercourse if all conditions are met. If the partner is positive, male partner is positive, but the male partner is compliant with the heart, that is a highly effective antiretroviral therapy, and the plasma viral load is less than 50 copies per ml for more than 6 months, and there are no other active infections, and if the intercourse is restricted to the ovulation period, then the transmission of HIV is less. Okay, so unprotected intercourse around the time of ovulation is advised. Okay, provided the male partner fulfills these criteria, that he is compliant with the heart, plasma viral load is less than 50 copies per ml for more than 6 months, there are no other active infections, and intercourse is restricted to the ovulation period. Okay, when all the above criteria are met, sperm washing does not further reduce the transmission risk, so natural conception or the unprotected sexual intercourse is advised. Okay, so sperm washing will not be recommended in this particular case. It may reduce the chances of pregnancy. Okay. Now coming to the when should we advise the sperm washing? So when the criteria are not met, so male partner is not compliant with the heart or the viral load is more than 50 copies per ml, sperm washing will reduce, but it does not eliminate the HIV transmission risk. So you go ahead with the sperm washing, but sperm washing will reduce the HIV transmission rate, but it will not eliminate the HIV transmission risk. Okay, so if the criteria are made, but the couple still feels the risk is unacceptable, then sperm washing may be considered after specialist discussion. So in spite of this, if she fulfills the if the husband is fulfilling the criteria, but if couple still doesn't want to take that risk, then sperm washing may be considered after the fertility specialist discussion. Okay, so insufficient evidence to recommend PrEP or for HIV negative women when all low risk criteria are fulfilled. So if the husband or the male partner is fulfilling all the criteria, then pre-exposure HIV prophylaxis is not indicated. Okay, because the transmission risk is very, very minimal. Okay. For partners of individuals with hepatitis B, what we have seen up till now was related to HIV. Now, what about the hepatitis B? Okay, in that particular case, offer vaccination before fertility treatment. Now, if other viruses such as rubella, so rubella testing should be performed, and if it is not immune, then we can give vaccination before the treatment, but pregnancy should be avoided for 1 month. Okay, so if the rubella, this also they are asking in the SBA, if she receives the rubella vaccine, how much duration she should avoid the pregnancy? It is for 1 month. Okay, then cervical screening, we need to ask the history of the last year, and as per the national program, the screening will be continued. We will also test for chlamydia screening, but if the chlamydia screening is positive, then uterine instrumentation, we need to treat the woman and partner before performing the test. Okay, and we also need to do the contact tracing. If not screen, then consider prophylactic antibiotics. Otherwise, what we will do, we'll give the antibiotics and then we will do uterine instrumentation. Or if she wants to undergo HSG, in that particular case, we will have to treat first and then do the HSG if she is a chlamydia positive. Okay, so these were the screening recommendations. So what is the take home message? So before referral for natural conception, up to 1 year natural conception they can try. If she is for IUI protocol, 6 cycles. If her age is 36 or more, then these are the referral triggers for the assessment. Okay, so age is the best predictor for the ovarian reserve. Okay, HSG is the first test unless there are comorbidities. Then routine prolactin, TFT, endometrial biopsies are not indicated. And if the HIV is well controlled, then natural conception is acceptable. Even the PrEP is not indicated. Okay. Now coming to the male factor infertility management. Okay. Now, if it is a case of hypogonadotropic hypogonadism, in that particular case, gonadotropins are effective. Okay. And if there are idiopathic semen abnormalities, in that case, we are not supposed to advise anti-estrogen, gonadotropins, androgens, bromocriptine, kinase enhancing drugs. So these things are not recommended. So suppose if there are idiopathic semen abnormalities, then please do not select these options. Now, suppose the report is mentioning that first thing, we are not supposed to screen for the anti-sperm antibodies as per the guideline. But if the anti-sperm antibodies are positive, its significance is not clear and systemic steroids are not proven. So we will not give the steroids also. Okay, ideally the anti-sperm antibodies should not be tested. Its significance is not clear. But if your report is mentioning this, please do not select the systemic steroids. Okay. Now, if there are leukocytes in the semen, should we give the antibiotics? What does the guideline says? Antibiotics are not required unless the infection is identified. So you should send the sample for culture, and if there is infection, then only you give the antibiotics. Otherwise, empirical antibiotics are not indicated. Okay. Continue with the male fertility treatment. Suppose there is a obstructive azoospermia, then surgical correction of the epididymal blockage. Okay, that is an alternative to IVF and sperm retrieval. Okay, so two options are there. One is a surgical correction of the epididymal blockage, and second will be alternative will be IVF plus sperm retrieval. Okay, varicocele, again they have given the scenario in the past where there is a varicocele. The surgery is not recommended because NICE guideline does not recommend any surgery for the varicocele. Okay, there is no pregnancy benefit. If it is an ejaculatory failure, then treatment may restore fertility without ART, and evidence is limited and individualized management is to be done. Now, this is what about the male infertility. Okay. Then coming to the ovulation disorders. WHO has classified ovulation disorders into 3 groups: group 1, group 2, and group 3. Okay. Group 1 is a hypothalamo-pituitary failure. Group 2 is a hypothalamo-pituitary dysfunction like PCOS, polycystic ovarian disease, comes in group 2. Okay. And group 3 is ovarian failure. Okay. Please remember these 3 groups. Group 1 is a hypothalamo-pituitary failure. Group 2 is polycystic ovarian disease, that is hypothalamo-pituitary dysfunction. Group 3 is a ovarian failure. Okay. Now coming to the group 1, that is hypogonadotropic hypogonadism. Here mainly the lifestyle advice is going to be very, very important. Okay. Most of the time in such cases, the BMI is low or there is excessive exercise. So they should reduce the exercise and they should increase the weight. And if her BMI is less than 90. Okay, so that is what is the lifestyle advice which we need to give. Then ovulation induction, pulsatile GnRH can be used or gonadotropins with LH activity. So that is what you can use it for ovulation induction in hypogonadotropic hypogonadism. See, when we are discussing group 1 and group 2, there is a little difference for in the selection of these ovulation induction agents. So in group 1, you can use pulsatile GnRH and gonadotropins with LH activity. Now we'll see in the group 2 what the guideline is mentioning. So for group 2, first line management general principles are applies to the WHO group 2 ovulatory infertility, and management will depend upon the BMI, response to the treatment, side effects, monitoring needs, and the patient preference. Okay, most of these patients will require lifestyle advice. If her BMI is more than or equal to 30, they should be advised to lose the weight. Okay, so weight loss if she is having the BMI of more than 30. So even if there is a weight loss alone, that will restore ovulation, improve response to the ovulation induction, and improve pregnancy outcome. Again, this is the EMQ which has been asked in the past. They'll give you the scenario, they'll give you the semen parameters, they'll give you the BMI, age of the lady, and they will ask you what is recommended. Okay, then look for the duration of the infertility. So up to 1 year, it is a natural conception they should try. And if it is a BMI of 30 or more, you need to advise only the weight loss. So don't just go ahead with the ovulation induction. Look at the BMI, because only weight loss alone will restore the ovulation, improve the response to the ovulation induction, and improve the pregnancy outcome also. Okay, so in that particular case, you will select the weight loss. Okay, then coming to the first line ovulation induction options, such as clomiphene citrate is the first line ovulation induction. Then there is a role of metformin. It is useful, especially in overweight PCOS, and clomiphene plus metformin can be used as a first line, especially in a obese PCOS. Okay. Now, when we are using clomiphene, certain things which we need to keep in mind, that at least in the first cycle, we'll do the ultrasound monitoring. Okay, at least in the first cycle. So that we'll come to know that will reduce the multiple pregnancy risk. Then maximum duration should for the clomiphene citrate should be 6 months. Okay, do not continue beyond the 6 months. Now, for metformin, counseling inform about the side effects such as nausea, vomiting, gastrointestinal disturbances that we need to discuss. Okay. Then there is a clomiphene resistant WHO group 2 disorders. Okay. Now she is a case of PCOS. You have started on clomiphene, but she is resistant to clomiphene. There are two concepts. One is a clomiphene failure, and second is a clomiphene resistance. Now, what is a failure and what is resistance? Failure means she is ovulating, but there is no conception. That means the this clomiphene has failed. Okay. Clomiphene resistant means there is no ovulation in spite of increasing the dose of clomiphene also. Okay. So what are the second line treatment options? This is also SBA or EMQ from part 2 MRCG point of view. Okay. So we have three options. One, you can go ahead with the laparoscopic ovarian drilling. Second, you can add metformin. So if she is only on clomiphene, add metformin. Third is a gonadotropin option. Okay, so these are the three options. But look at the scenario and choose, because all three options will be given there. But choose, you have to choose only one. So how will you select? Again, read the scenario carefully. Look at BMI. Okay, so if the weight loss has been advised, clomiphene is started, then you can make clomiphene plus metformin if it is not already been used. If the patient is non-obese and LH levels are high, then go for laparoscopic ovarian drilling. Okay, so that is an alternative second line. And gonadotropins, it is effective, but it needs strict monitoring. Okay, so you will read the scenario, then you will select the option. Now, what is not recommended? Like GnRH agonist with gonadotropins, adjuvant growth hormone, and pulsatile GnRH, these are not recommended. Okay, so in the previous slide, what we mentioned is for group 1, pulsatile GnRH or gonadotropins with LH activity. Okay, so that was the use. Here, GnRH agonist with gonadotropins is not recommended. Okay, pulsatile GnRH not recommended. Okay, gonadotropins you can give. Okay. So this is what is the about the ovulation induction. Now what about hyperprolactinemia? Okay, so if it is a hyperprolactinemic amenorrhea, ovulatory disorders due to hyperprolactinemia, what you will advise? You will advise dopamine agonists such as bromocriptine. Prescribing should consider safety in pregnancy and cost. Monitoring during gonadotropin therapy. Before starting, counsel regarding one, multiple pregnancy risk, and OHSS. These two things, when you start gonadotropin therapy, two things we have to discuss: multiple pregnancy and ovarian hyperstimulation syndrome. Okay. So during treatment, mandatory ovarian ultrasound monitoring to assess follicular size and number. So monitoring is must when we are doing the ovulation induction. Okay, with gonadotropins. Then key take home message: BMI more than 30 or more, weight loss is first, then clomiphene USG monitoring at least in the first cycle, and give it for maximum 6 months. Then if it is a clomiphene resistant, we will choose one of the three, that is clomiphene plus metformin if already not used. Then other option is laparoscopic ovarian drilling. Third option is gonadotropin. Okay, GnRH agonist growth hormone, they are not recommended. Okay, gonadotropin, you have to counsel regarding multiple pregnancy and OHSS, and ultrasound monitoring is must. Okay, so these are the things which we should remember. So if the question says clomiphene resistance PCOS, always look for add metformin or LOD, that is laparoscopic ovarian drilling or gonadotropins. Okay, I hope this is clear to all of you. Now the guideline also talks about the tubal and uterine surgery. Okay, so if it is a mild tubal disease, there is no role of tubal surgery. Okay, so for mild tubal disease, tubal surgery is not indicated. If there is a proximal tubal block, then what is recommended? What you do is a tubal cannulation or selective salpingography. Okay, proximal tubal block, select tubal cannulation or selective salpingography. Okay. Then if it is a hydrosalpinx, then before IVF, you will recommend salpingectomy before the IVF. That will increase the live birth rate. Okay. Now, uterine surgery such as intrauterine adhesions, if they amenorrhea, hysteroscopic adhesiolysis can be done. For endometriosis, we'll follow the NICE guidelines and ICSI guidelines. Okay. So we have finished the subfertility NICE guideline. Thank you.